Thank you, Dr. Ahmed. It's my pleasure to be here. I'm delighted to be here for the second Artificial Intelligence Forum organized by the PARS, and I'm very thankful for the organizing committee for having me. My talk today is Artificial Intelligence in Cardiovascular Care, from innovation to clinical applications. I don't have any conflict for this talk, and any company names, I'm going to mention it just for the sake of the products they are developing. As you know, artificial intelligence has been conceptualized by John McCarthy in 1956, and it implies the computer science in which we try to train the computer, the machine, to think and reason and react as a human brain. We can think about it as the ability of the machine to make autonomous decisions based on data. So in medicine, artificial intelligence namely means data, big data, that we derive this data from electronic medical records or from imaging, and we use them to identify new disease or discriminate between different pathologies, or to help us or guide us for the choice of treatment. It does exist in our life, from the self-driving cars to Siri to the robot that has some of the human characteristics intentionally, and to facial recognition that we used in our phones and other applications. And this is the cartoon shows the AI universe that includes the artificial intelligence in general, the term, and there is a subdivision of the artificial intelligence, which is the machine learning. In machine learning, we are training the machine to perform certain tasks, either supervised by the human or unsupervised or semi-supervised, to come with an outcome to create certain features. Well, the subdivision is the deep learning. In deep learning, we are using more complex structures that called the convolutional neural networks for autonomous or automatic extractions of these features without help of the human. And now, the fourth subdivision is the generative AI that includes the transformers, the language translations, and chat GPT, and so on. The unit of artificial intelligence is the neural network. And this can be either a simple neural network composed of one input layer, a hidden layer, and one output layer, or the deep learning neural network that's called CNN, convolutional neural network, composed of one input layer and many hidden layers, and then the output layer. And you can imagine or can appreciate the difference between the two types is that the one to the right will extract more complex tasks and trying to find or to reclassify any features in the data to come with the output. Well, cardiovascular medicine is one of the most important subspecialties using artificial intelligence. I copied this data from Cardiovascular, published almost a couple of months ago, and it shows the incremental increase of the using of the AI products in cardiovascular medicine. From all the products submitted for FDA clearance, we have about 90 cardiovascular products. That comes in the second position after radiology, of course. That's represented the most of the products. So the share of cardiovascular AI-enabled or AI-based products is about 10%. But if we add the products which are common between cardiology and radiology, that raises the percentage to 17.4%. Artificial intelligence is poised to transform every facet of cardiovascular practice. So now the physicians, researchers, scientists are incorporated the AI-based programs in their daily practice. And thanks for the digitalization of health data, the transformations, and the computation models that enable us to move from the first stage, which was just encoding human knowledge, to augmented human knowledge, the second stage, and performing task-specific unimodal task, to now to task-agnostic, multi-modal, never before seen tasks. So extraction of data that are hidden. So that's the journey or the progression of artificial intelligence usage in medicine and also in cardiovascular disease. And now the question, what are the spectrum of artificial intelligence in cardiovascular disease can be huge, or now actually it is. And that includes mainly, number one, innovation in disease diagnosis. As you know, traditionally, disease diagnosis has been based all the time on human-led interpretation of multimodal input in history, clinical examination, imaging, and test interpretation. The earliest studies using AI, machine learning, focused on developing tools that relied only on structured tabulated data derived from the health records. Their focus was to standardize an efficient screening of cardiovascular disease so that several machine learning algorithms capture nonlinear relationship and may be more effective than traditional linear models created by humans. But these models were not successful, especially when we compare them head-to-head with the individual models. But instead, AI might offer the greatest value by identifying sources of phenotypic variations and risk in complex signals rather than tabulated data. With advances in deep learning, such as the CNN and transformers, AI algorithms can process now raw data, unstructured biometric signals and image, learning new representations from this data beyond what is manually encoded. One of the best examples of that is using ECG-enabled programs or models to detect the paroxysmal atrial fibrillation from the baseline EKG. But more than this, extending the ECG model to detect the cardiomyopathies and to detect the pathologies in the form of cardiomyopathies or depression of left ventricular function before the disease happens. So we are training the program to detect the anomalies at the cellular level, at the cellular remodeling level before the clinical cardiomyopathy phenotype or the symptomatic disease. And AI further enable opportunistic screening of cardiovascular disease across imaging modalities. We can see that now we have programs for prediction of coronary artery calcium and cardiovascular risk on chest X-ray, just normal chest X-ray. We can predict the calcium scoring and the risk of cardiovascular disease. Also can be extended to prediction of valvular lesions, like diagnosis of aortic stenosis from chest X-ray using the deep learning model, and on the not only diagnosis of aortic stenosis, but also evaluation of the degree of aortic stenosis, mild, moderate, severe, and differentiation between valve calcification and wall thickening. All this using the advanced deep learning machine. Not only structure, but the function. We can predict the left ventricular function just using the chest X-ray. Across all of these applications, scrutiny is required to ensure the diagnostic signal learned is directly linked to the label of interest rather than confounders. The scalability of these programs, AI-based programs in cardiology, can be augmented if we add them to the normal screening imaging we are doing in daily practice. So we are using the AI models to predict certain disease while we are doing screening for other disease. An example of that is detection of coronary calcification as a metric of cardiovascular risk on low-dose computed tomography scan for lung cancer, or detection of microcalcification during a mammography screening of breast cancer as a novel cardiovascular risk enhancer among postmenopausal women. So that's another level of using AI-based programs in cardiovascular disease. The third element is integration of automated pipelines into routine cardiac diagnostics. And actually, this is one of our daily tasks we are using. And if I can say something, this is the most applicable or the widely used methods of AI-enabled programs in cardiovascular medicine. That includes automatic labeling of the cardiac chambers in echocardiography. Not only that, but if you look at this model, you can see the machine is directed the imager or the cardiographer to adjust the position of the probe. Till you have this sign of the green heart, it means you are in a proper position for image acquisition and taking the measurements. The same thing for a Doppler. Automatic Doppler signal can be put automatically over the valve and shows the Doppler measurements. We came also with a 3 model, AI-based 3 models for the cardiac chambers to evaluate the left ventricular volumes and the left ventricular function, and that's based on also on deep learning, but it allows us to do some editing or modification, and this is actually precisely measure the left ventricular volume and function better than the regular measurements, because it divides the cardiac cycle into different phases, so precisely give the measurements of the left ventricular and left atrial volumes. Not only the structures, but the function. We have such models from the echocardiography to measure the left ventricular contractility and the global left ventricular strain and the segmental wall motion abnormalities using an AI-based program. Cardiac CT, it's a big time modality. Using the AI programs, we can now automate the calcium scoring. You don't need to do any manual click. The image just pops up, and you find the software just labeling the calcium at the different coronary arteries and give you the automatic calcium scoring. But the most important element now, in my opinion, using the AI in cardiology, coronary artery disease, and in cardiac CT, is the segmentation, coronary artery segmentation from CCTA for luminal grading and plaque assessment. So historically, with the imager, the cardiac imager, or either a radiologist or cardiologist were focusing mainly on the lumen stenosis. But now we have this AI-based programs to give us a detailed plaque components analysis. So it gives you actually how much calcium, or what is the calcium volume, the lipid volume, the fibrous volume, and not only that, but also it determined the high-risk plaque features. In cardiac CT, we have the expansile remodeling, the spotty calcium, the low attenuation plaque. So actually, it provides you with the high-risk plaques that mostly will cause the future events, not only the stenotic plaques. And why we are interested in that? Why an imager or radiologist or cardiologist are interested in that? Because what's called the plaque power. The plaque power is that's the number of segments affected by coronary stenosis now is as important as, or maybe more important than, the stenotic segment, especially with this high-risk plaque features concept, because now we have in cardiology and the interventional cardiology what's called the preemptive intervention. That means if you predict this plaque early, you can intervene either by increasing the medications, statins or whatever the medications, or there is a trend now towards using preemptive or preventive stenting to treat this plaque. So that helps us a lot in decision making. And if you see here the presence of this high-risk plaque features like the positive remodeling and low attenuation plaque and spotty calcium, triple the risk of coronary artery disease, the future events, and the acute coronary syndrome. Again, for the same thing can be applied to the MRI for evaluation of the global and segmental motion abnormalities and evaluation of the cardiac function precisely based on the AI-based programs. Not only the structure, but the flow, the hemodynamics. A big real-time applications of AI-based programs in cardiovascular medicine is to simulate the flow or to modulate the flow, especially from the 4D MRI, as you can see here in this model, just for the diagnosis of the aortic regurgitation. This is the forward flow of blood in yellow or orange, and the backward flow of blood from the aorta towards the left ventricle that can be used to diagnose the aortic regurgitation, to evaluate of the left ventricular outflow tract or the aortic aortic route for aneurysm or dissection, and for evaluation of the aortic valve. That can be applied also to the other cardiac structures. But more importantly now is not the diagnosis, but the early detection of the disease. So we have models now for early detection of coronary inflammation using cardiac CT. They are using the metrics, what's called the perivascular fat index attenuation. This is an early metric or early sign of coronary inflammation and coronary atherosclerosis, and based on that, we modified the guidelines for treatment of coronary artery disease and myocardial infarction, and we are giving colchicine now as an anti-inflammatory medication for treatment of acute myocardial infarction or acute coronary syndrome. Well, the other aspect of artificial intelligence program in cardiovascular medicine can be improvement of image acquisition, processing, and radiation dose reduction. I cannot find any better example than the photon counting CT, which we are using now in our hospitals, some hospitals in the United States. It's an expensive machine, but we were lucky to have it. And I have to be cautious to present the physics in front of radiologists, but I will try. So the normal CT is that we are actually transforming X-ray into light, which is a bunch of photons or arrays of photons. Then we are dealing with this arrays of photons using what's called the energy integrated scintillator. But in photon counting CT, instead of 3 steps to change the X-ray, we have only 2 steps. So we move from the X-ray to single photons. That will be translated into smaller detector pixels, elimination of electronic noise, and intrinsic spectral sensitivity, and equal energy contribution. So the machine itself, the physics, is not based on AI, but the components of the machine are based on AI or AI enabled. So you have, for example, specialized camera to centralize the patient. You have the table that will also move automatically for proper positioning of the patients during acquisition. And more importantly now, you have the automatic detection of the variability of the heart rate that will adjust the radiation dose and the protocol based on the patient's heart rate, and adapt signal to noise based on the scout or the topogram. Based on patient's weight, you can modulate the radiation dose and adjust the signal to noise ratio. All this is AI based, and the result is to have such an image. So this will help us a lot in decreasing the false negative and false positive results. Even as you can see here, even the stents, you can see the details inside the stents, the struts. This is a stent in the LAD, in the left anterior descending artery, and you can see clearly within the stent. So what does that mean? That will be translated into also decrease the error, decrease the time, decrease the negative and positive cases, false negative and false positive cases, and also increase the revenue and save the hospital resources. Then the next element will be the AI is helping us in decision making and management plan. Also, the best example of that we are using now in cardiology and cardiac imaging, what's called the FFR, the functional flow reserve. I will try to simplify that. The functional flow reserve is a metric of drop of pressure across the stenosis in the coronary vessel. So we are taking the drop of pressure as an indicator of decrease in blood flow. Because in the cath lab, what we need to know whether this lesion is a flow limiting or ischemia producing or not. So the way of doing that is to pass a pressure wire invasively in the cath lab and distally to the lesion, to the stenosis, and measure the drop of pressure across this stenosis under maximum hyperemia. The hyperemia will stabilize the resistance, so the pressure will be in linear relationship with the flow. And our cut point should be less than 0.8. That's the positive cut point that indicates ischemia or flow limiting lesion. We were using that in the cath lab only, but now we can modulate that from the non-invasive imaging from the CT. And the methods which was used till a couple of years ago or 3 years ago is taking the CT image or acquiring the CT image and create an anatomical 3D models and use what's called the computational fluid dynamics. Computational fluid dynamics is a method for calculation of the blood flow using the blood viscosity and the velocity, and then to solve a complex equation called Navier-Stokes equation through the computer. And come with this color-coded 3D mesh of a FFRCT based on non-invasive imaging. But now, with the help of artificial intelligence, we can do that using deep learning. So we create the geometry of the vessel, we simulate the coronary artery, we simulate the stenosis, we simulate the hyperemia to do the measurements or to calculate the measurements of drop of pressure within the vessel. There are many vendors in the United States doing this technique. And this is just an example of the outcome of one of the cases. And as you can see here, it is color-coded, and it depicts the 3 coronary vessels, and the color from red to blue, the FFR negative will be blue, and the positive will be towards the red. And here, as you can see, I can navigate through the vessel to specifically localize the area of stenosis that produced the flow limiting or the ischemia. Not only that, but also in case of it has been validated, of course, the FFRCT has been validated. If you see, this is the CT image, this is the LED, and this is the measurement using computational fluid dynamics. The FFR is 0.76. Using the machine learning is 0.76, the same, and our invasive measurements in the cath lab is 0.75. So very compatible and very matched with the invasive technique for measurements of the pressure inside the coronary arteries, and that was the base to adopt this technique now in decision making to refer the cases to the cath lab or not. And as I said, it's localized the presence of ischemia when you have a focal disease, but also when you have a diffuse disease, we are doing what's called the pullback measurements to see if there is a pressure step up, so we can see where to stent. And nicely, we can simulate the stent. As you can see here, the program is showing you after you put your stent, what will be the pressure. So it predicts the results before bringing the patients to the cath lab. So here is an example. That's like the FFR was here positive, and this is after we put the stent. Not only on catheterization, but this is a very interesting study performed by Professor Patrick Serrais. He's a big intervention cardiologist in Netherlands, to do CABG based only on cardiac CT and FFR CT. So like using only the CT, this patient didn't go to the cath lab for coronary angio. They did coronary CT angio and measurements of the pressure within the vessel and where to put the lima. And here, after the surgery, they put the lima, the left internal mammary artery, over the LED just based on the CT measure. Another big time usage of the AI-based programs in cardiology is using them in a structural heart disease intervention. And our main model was to, the first model and the main model was to be used in TAVR, transcatheter aortic valve replacement. Now we are doing the aortic valve replacement based on the cardiac catheterization. So this program can provide automatic analysis of the annulus based on which we size our valve. It can provide nicely the calcification in color over the aortic valve, because the degree of calcium over the aortic valve will determine the success of the procedure. The size of the valve and the inflation of the valve. The distance from the coronary arteries, which also will determine the complications, and nicely depicted the aortic root to see if there is a calcification or not, also providing the peripheral vasculature, because this is the site you're going to put your introducer to mount the catheter. Not only that, but those softwares or programs, they simulate the valves. As you can see here, this is the angiographic view we are providing to the interventional cardiologist, and here this is the valve. This is before bringing the patient to the cath lab. But when you pick the size of the valve, you can simulate it to see what's going to happen after you put the valve, whether it is displaced a little bit in the left ventricle, you need to push it up, down, and you provide all this data for the operator in the cath lab to work based on that. This is a nice model, also used in the cath lab. It gives you an automatic analysis of stenosis, degree of stenosis in the coronary arteries during coronary angiography, just after you inject the dye. So you inject the dye, it gives you this nice color-coded analysis of the vessel, which helps you to reduce the amount of dye you're gonna use, and also reduce the time you're gonna use for analysis of the vessel visually, or even offline analysis on the workstation. Another example, this is from Philips. It's called Echo Navigator. Combined data from echocardiography, transesophageal echocardiography, and angiography to come with this 3D models of the valve. Look at that. It simulates the position of the valve. So you are not going blindly. You know where the mitral valve, the aortic valve, and you can manipulate your wire based on that. So artificial intelligence is actually helping us a lot now in the cath lab or outside the cath lab or in the reading room of CT or echo for decision making. And additionally, one of the elements we are talking about now is the digital biomarkers of disease risk. Those elements, actually, we can use them, or models or softwares or devices, we can use them in our daily busy practice. The metrics available on these devices, such as step counts, heart rate variability, and sleep quality, are a strong predictor of cardiovascular health and outcome. And as you can see, that includes the wearable watches, the monitoring devices for heart rate variability, for blood pressures. We have some patches. We are using them to monitor even the ICD, the implantable cardioverter defibrillator. And thanks for the pandemic, that gave us some access to virtual monitoring of those patients and using those disease. We have novel models of disease prognostication. The importance of those AI-based programs can be augmented by combining this data, the data we are collecting from images and electronic health records together. So creating such models will help us for disease prediction. So this is a model for predicting survival from echocardiography and health records data, electronic health record data. And as you can see, combining this data together, the performance of the model, the performance of the model was superior to just the left ventricular outflow, the left ventricular ejection fraction, or the echo measurements alone. The same thing, we can use deep learning model for predicting obstructive coronary artery disease from the myocardial perfusion imaging in PET scan, in cardiac PET scan, or even we can use a multi-model analysis or a multi-model algorithm that include metrics from clinical data age, calcium scoring, LDL, and systolic blood pressure, and combine this together to come with a risk predictive model for the population. And the nice thing now is that we can modulate that not only to a general population, but a specific population of a specific area. So we can collect the data from Saudi Arabia or from Emirates or from everywhere and include a specific model, will come with a risk model just for the people of Saudi Arabia, or even just for a localized area of the Saudi Arabia or an area of Dubai. And finally, the last thing is the use of AI-enabled programs or AI-based programs for disease analysis or analysis of the causes actually of the disease, including, of course, the virtual assessment, or as you can see here for that's like a fancy cinematic view of the mitral, of the tricuspid valve and the aortic valve, and use it for evaluation of the anatomy and the pathology. That's, will help us to diagnose the disease and understand the mechanism or pathology beyond it. This is a nice model from Siemens. It's called Twins, digital twin of the heart, that includes data from ECG and cardiac MRI to evaluate or to study the normal cardiac contractility in the model to the left, and the cardiac contractility after recovery from the open heart machine. As you can see, firstly the fibrillation of the heart, and then it's going to stabilize, or to study the mechanism of cardiac arrhythmias like re-entry phenomena or other features after loading the myocardium with potassium. So as you can see, artificial intelligence is penetrating the field of cardiovascular medicine in different aspects, in diagnosis, in supporting treatment, patients follow-up, and risk prediction. So in conclusion, ladies and gentlemen, over the next decade, AI technologies will become a core component of the diagnostic, prognostic, and therapeutic cardiovascular toolkit. Unimodal and task-specific models will likely be superseded by task-agnostic, multi-modal, and semi-autonomous systems, effectively augmenting rather than replacing human intelligence. Innovation in data acquisition through wearables and portable technologies are expected to further broaden the scope of AI solutions focused on cardiovascular health monitoring and screening. Concurrently, AI-driven integrated multi-omic environments will enable deeper phenotyping and redefine disease classification, guide biomarkers discovery, and the development of novel therapeutics. Please, if you have any questions, don't ask me, ask ChatGPT. Thank you so much.